African sleeping sickness is commonly misdiagnosed. Cankers and lymphadenopathy mimic pyogenic skin lesions and lymphoma respectively. CNS involvement is often so subtle and varied that human African trypanosomiasis must be considered with any new psychiatric or neurologic abnormality that develops in endemic areas. Definitive diagnosis of human African trypanosomiasis requires recovery of the parasite from the host. Trypanosomes can be identified through peripheral blood smears, aspiration of a canker or an enlarged lymph node, and lumbar puncture. Serial blood smears should be performed if the initial ones are negative, given that the level of parasitemia can fluctuate. Lumbar puncture is mandatory for all patients with African sleeping sickness to assess for CNS involvement. MOT cells, which are abnormal plasma cells with vesicles containing IgM immunoglobulin, white blood cells greater than or equal to 5 per microliter, and/or protein greater than 25 milligrams per 100 mL, are all consistent with late stage of disease. Differentiating between the two trypanosomal subspecies is based on travel history and chronicity of the disease, given that they are indistinguishable on microscopy. The card agglutination test for human trypanosomiasis, or CATT, is a field laboratory test for serodiagnosis of African sleeping sickness. However, this test is only available for T. brucei gambiense. It is useful for screening for West African trypanosomiasis because of its high sensitivity of 94 to 98%, but cannot be utilized for diagnosis given its variable specificity. Therefore, further testing for definitive diagnosis is required for those with positive CATT or the card agglutination test.